Thank you, Helene, and thank you for the organizers for organizing a very stimulating day to intersect three disciplines or integrate oncology, acupuncture, and fascia. I do think it is really important for us to get out of our comfort zone to really think out of the box in order to solve some of the problems that we are being confronted. At least in the area of oncology acupuncture, I think we are really at a really important time because we have some very promising preliminary data, but we also need large and definitive trials. And more importantly, like in the rest of the field of acupuncture, we're confronted with sham acupuncture, the placebo effect. So I hope to use my research to demonstrate some of the potentials for us to innovate in our trial design and to really eventually provide evidence to change the way we care for cancer patients. So I have no conflict of interest to disclose, but the research findings are supported by the National Center for Complementary and Integrated Health. However, it does not represent the views or opinions of the National Cancer Institute of Health. So I have to thank Dr. Lu Dong from Dana-Farber Cancer Institute to provide this slide. It really demonstrates the field of integrative oncology acupuncture is an exciting, thriving field, has really been taking off since the early 2000s. So as any new scientific discipline, it takes time for the field to mature. So for those of you who are on the brink of entering a research career, this is a really exciting, the next 10 to 20 years are the time frame we're gonna really make an impact. So thanks to the work of Dr. Kay Casilla as well as Lorenzo Cohen's group for providing a really eloquent systematic review published in Journal of Clinical Oncology last year. So where you can see there's a clear evidence for acupuncture for chemo-related nausea, vomiting, but there are a number of areas, as you heard this morning, describing promising areas requiring well-designed, adequate powered studies to provide definitive evidence. Today, my focus is on talking about cancer pain. Specifically, I will talk about aromatase inhibitor-related arthralgia. So my area of research actually started with a patient I was introduced. Her name is not real for the sake of providing her privacy, but the rest is real. So she is a 61-year-old breast cancer survivor diagnosed with stage 2 breast cancer with ER-positive tumor. After finished chemo, she was prescribed Arimidex, a standard sort of hormonal treatment for postmenopausal women. So being on that drug for 6 months, she's complaining diffuse body aches, worse in her elbow. She's a very active tennis player, and playing tennis means a lot, and not being able to play tennis makes her feel she is just being trapped in a very old body that she's trying to get out. She's like, I feel like just my mom. When I get out of the car, I have to just, push myself. So she's contemplating whether she should stop this life-saving drug. Just to put this story into context of statistics, 1 in 2 women on this drug has body ache we know as aromatase inhibitor arthralgia. About 30% of patients prematurely discontinue this drug. And premature discontinuation is associated with both disease-free and as well as overall survival. So as you can see, this is a really important symptom, not only affecting quality of life and functions, but almost threaten the survival of breast cancer patients. So at that time in 2007, University of Pennsylvania is extremely conservative. Her oncologist does not want her to try anything other than stopping the drug. But her nurse practitioner was much more open, sent her secretly to me to get acupuncture. So thanks to the work of Brian Berman, Claudia Witt, at that time there's a good evidence for acupuncture for treating arthritis. So I told her, I have no experience treating this condition, but there's good evidence it may help arthritis. Let's give it a try. Note to behold, 6 treatments later, her pain was completely gone, and she was able to resume her tennis. And about 3 years later, I'm doing a large NCI-funded clinical epi study on genetic determinants of AI arthralgia. My research assistant saw her. She's still on her AI and doing great. And, but I want to give you a hint. This case actually stimulated this line of research for the last 8 years. In 2007, when I surveyed breast cancer survivors at University of Pennsylvania, only 4% of them use acupuncture. But today, 17% of them have incorporated acupuncture in their care. So I think it's through careful research and integration, we can make a difference. So this study first started by a feasibility trial. It's a single-arm trial. So I really want to emphasize doing phase 1 trial is really important. Unfortunately, in this field, a lot of the trials are designed by people actually know very little about acupuncture. In the spirit of pursuing science, a lot of people say, let's just do it. Let's do it, find 4 points, let's go for it. And that's really bad because surgeon would never do a surgical intervention like that. Medication chemotherapists would never just run through some random drug, say, let's go for RCT. You're bound to going to be finding a negative trial. So in this study, what I did is actually I have conflict of interest because I did all the interventions because nobody knows what the symptom is. So as a Western trained physician, I evaluated the patient, applied to the TCM principle. I called my colleagues in China. I had 2 wonderful acupuncture friends, Lorna Lee, who is in the audience somewhere, as well as Adam Schreiber. And we really thought hard, what are the symptoms from a Western perspective, what are the Eastern perspective, and we eventually developed a protocolized therapy. I really want to thank people like Rosa Snyder for really advocating for those kind of protocolized therapy, really allow acupuncture to be done in a way you can reproduce the findings, but also reflect the principle of individualized treatment. So as this pilot, we found acupuncture is not only safe, but really produce a clinical meaningful effect size in reduction of pain from about a 5 to a 2, so that's about 3-point reduction, as well as in associated anxiety and fatigue. So that led to an NIH-funded R21 trial on electroacupuncture for aromatase inhibitor of related arthralgia. So the bottom line is, as a trial design, this is a phase 2 trial. We are limited in our sample size, so our primary aim is set to compare with electroacupuncture against usual care. And our secondary aim is to explore the potential effect size between the electroacupuncture and sham acupuncture. I also think it's really important, when you have a sample size of 20 to 20, it is unrealistic to expect anything active is going to beat sham or placebo. That is true for drugs. That is true for acupuncture. That is probably true for all the interventions. Because the noise of daily life is just really big and unforgiving. If you design a small, underpowered trial and set your hypothesis wrong, you're bound to have the wrong conclusions. So our interventions is everybody are educated by joint pain and informed to stay physically active, continue to stay active medical care, including receiving their pain medication. Again, this is what standard oncologists do. They probably don't actually go into depth to talk about all the physical activities. And we had 2 non-physician acupuncturists. This time, I removed myself from delivering the intervention, so I actually don't know the treatment assignment to maintain the sort of the blinding. And with years of experience, Adam and Lorna. And so they treat a patient twice a week for 2 weeks and treat additional 6 weeks. Our treatment is manualized protocol with a predominant treating joint symptoms based on the B syndrome described in traditional Chinese medicine. But we also allowed adding additional points to target fatigue, sleep issues, anxiety, depression, which are common in breast cancer survivors. And it's really important, I think, as we design trials in cancers, patients don't come in with one symptom. They often come in with constellation of symptoms. Later on, we'll show you on those secondary outcomes. And we chose electroacupuncture. Part of it is there's an abundance of basic science literature suggests the specificity of the neuroscience in acupuncture analgesia mostly is based on electroacupuncture. Our outcome measure include validated patient-reported outcome of joint pain, fatigue, sleep, anxiety, depression as secondary outcome. Use a mixed effects model is a longitudinal analysis model adhering to the intent to treat principle. So one of the most common questions I got asked by the oncologist as well as patient, how do you blind? How do you mask the acupuncture? The patients, I typically say, if I tell you, I have to kill you. So I never told the patient how I did it, at least the patient in my trial. But really, here's the example. On the left panel, so So basically, you can see the tip of the sham needle is very dull. It's actually not very dull because the diameter is still very thin. But upon contacting the skin, the real needle just goes through. The sham needle, the top will retract into the body. This is the Streiberger device. So the problem with this is the sham needle, the tip is still sharp. So really providing a sensory stimulation that really classically not like physiologically inert. That's just a limitation. Bear that in mind. So we enrolled close to 60 patients in 3 arms. We made an effort to have a really good non-minority participation, almost 30% of patients. 66 received anastrozole or the Arimidex. No difference in baselines. As expected, there's no serious adverse events. There were 18 mild adverse events in 398 acupuncture treatments. Most related to this needling sensation because it's blinded trial, so we couldn't really educate about what the chi is. So people just sometimes, So again, whether there's adverse events or not, but it's part of the acupuncture delivery. So I have to say, when I first got the results, I was kind of depressed. Oh, it's just another trial showing real is different than sham. But then, after digesting the data a little bit more careful, I become more hopeful. So the blue line is the real electroacupuncture. The red line is usual care. So our primary analysis found that electroacupuncture showed to have both a clinically important and statistical significant change with a Cohen's d of 0.76, that meaning a moderate effect size. So in general, and also if you look at absolute pain point joint is 2. So in a recent meta-analysis on all psychosocial education or drug therapy for cancer pain, rarely any intervention compared to usual care actually can reach to a 2-point reduction in cancer pain. So you can say electroacupuncture from this perspective is effective. But during the active intervention, actually, there's no separation between real electroacupuncture and sham. But what the difference is really like at the end, after 2 weeks without acupuncture, the real acupuncture group continued to improve. The sham started to regress. So this is actually even more clear for pain interference. This is a domain measuring how pain affecting their quality of life, function, sleep, so on and so forth. You can see a small but definitive separation over time. And if we power based on this difference, we need about 120 to 150 people in each arm. So we will need like somewhere between 250 to 300. So the caveat is I wrote a grant to NCI, got really great review, 5 percentile on the first submission. But eventually NCI decided not to fund it because this is an acupuncture study, it's too expensive. So I find myself in a quandary. I really want to do the science to advance our field, but our funder doesn't necessarily view this as a priority area. I can understand the resource is very scarce. So how do we really move this field forward? So I was literally very depressed for a while, but I'm hopeful. And here I want to show you why I'm hopeful. So this is the first part I'm hopeful, is you can actually see a much more clear separation in the secondary outcomes, in fatigue, in sleep, in anxiety, with the exception in depression, where electroacupuncture and the sham acupuncture almost produce similar benefit. But for all the other secondary outcome, there is actually bigger separation. So one could argue maybe acupuncture really where it wins is to treating the whole person. So again, I'm still in the recovering phase from not getting funded. So I am thinking about how to write my next grant to get funded. But I have to say I'm a hopeful person. So instead of getting depressed about not getting funded, so I applied a grant to PCORI to study our sleep outcome. Thank goodness I got first funded a PCORI integrated oncology trial, compare acupuncture versus cognitive behavioral therapy for insomnia. So at least I feel some science will advance. So for those of you who know and want to do research, you have to be persistent because this is a field only for the person who wants to survive. And so one of the things that always intrigued me and probably many people here in the audience is, why is there such a powerful effect? So expectation has been hypothesized as a key ingredient in this so-called placebo effect. So we used the data from this trial to ask two questions. The first one is, does baseline expectation predict outcomes in acupuncture patients, right? If you expect more, would you get more? The second question is, does the treatment effect change your expectation? That means if I give you something good, will you love acupuncture a little bit more at the end? So let's see what we find. So we, as a fellow, I had nothing to do except for developing a scale measuring expectation because there's really no instrument to measure that. If you don't have an instrument, how do you study? So this instrument was already, originally I developed in Chinese in China and then translated into English, and thanks to my good colleague, now it's in Korean. And so it's only 4 items, really simple. You can use in research and clinical context. And currently, a number of clinical trials are incorporating this measure in addition to mine. And the outcomes we use a really standard way to qualify responders, brief pain inventory, as well as using clinical global impression of change, meaning people reporting their joint pain much improved or very much improved after course of therapy. So here are the results. Let's first look at sham. So on the horizontal bar is really the baseline expectation. The lowest is 6 because people, if they have below 6, they didn't join the trial. The top one is 20. And the vertical bar is percent pain reduction at the end. So with every incremental increase in expectation, there's one incremental improvement in joint pain. So as you can see, the expectation really worked for people in the sham acupuncture group. So what is in the real acupuncture group? That's what we find. I have to say, I actually, as a clinician, I always thought people, if they expect, they may do better. But what we actually found that the real electroacupuncture had no influence on the pain outcome. And in conventional pain research, we consider 30% of more reduction in pain is a clinical important change. So one way to interpret this is electroacupuncture provide a consistent benefit for patients regardless whether you expect acupuncture work or not, versus sham acupuncture really worked for people who believe it. Another way to look at this data is, so I validated this instrument in breast cancer outpatient patients. In my validation cohort, the mean expectation is about 9.8. Who are in my trials? The mean trial mean baseline is 14.2. So this is a critical issue in clinical trial in all therapies, whether it's drug or acupuncture. Motivated people participate in trials. Like they are not your typical patients are dragged in by their spouse or at last resort, just want to be curious about whether this worked to do. So as you can see in the real population level, if you give sham, you produce almost no benefit. If you do real, you probably have 40. But also it does raise a question. If you have patients come in with very high expectation, literally, doc, I mean, I have those patients, like, I think acupuncture is the best thing. It's going to work for me. In that context, maybe providing very gentle stimulation is all you need. So next, let's take a look what happens with expectation. This is in the sham group. So the people who we are considered responders in the sham group, they came in with high expectation, they left with high expectation, compared with people who did not respond. So really, there's really a responder status significance. So really, doing acupuncture doing sham acupuncture did not change the expectation. But that pattern is very different to electroacupuncture. What we actually found is they came in with the same set expectation, but as the intervention goes, the responder gradually increased the expectation, the non-responder gradually decreased their expectation. So what this really tells me is there's something really interesting going on. It almost like this is a classical conditioning. It's like your body have to respond, and then your mind start changing in electroacupuncture. So that's what I'm proposing. Certainly we have a lot of brighter people like Natalie, Richard here. I think maybe electroacupuncture is a body-mind therapy. The body has to respond to the treatment, the mind starts changing. And versus the sham acupuncture could be really a mind-body therapy. You come in expecting it to work, eventually it works for you. So this leads to, is it possible there are different ways? Because as acupuncturists, we know there are different ways we stimulate the needle. Some people we really stimulate very minimal, like in the Japanese needling, or there are some people we definitely don't respond to anything but electrostimulation. So I think there is a great potential for personalized acupuncture treatment. So this slide, I think many people have seen. This is by biostatistician at Memorial Sloan Kettering, Andrew Vickers, shows in a meta-analysis in lung cancer patients, acupuncture produced both specific needling effect and overall effect. So the specific needling is only about half of the effect size, and the rest is the process effect. So one thing as an acupuncture practitioner, I think we all recognize acupuncture is not just science, it's a healing art. So what I would consider as the specific needling effect is the science. The process of acupuncture, that carrying delivery of that process is the art. So I would really challenge us as we research acupuncture, we don't lose the art of acupuncture. Because if you lose it, we lose the soul of acupuncture. So I think as we design our trials, we shouldn't just always try to control away. Maybe there are other design methods we should actually embrace it, to enhance it, to really improve this overall acupuncture effects. Let's get into a little bit more about this placebo effect. This study just published this month in Journal of Clinical Oncology. It's not about pain, it's actually about hot flash. So we randomized 120 breast cancer survivors with hot flash in 4 groups. So this deep green, this green is real electroacupuncture. The blue is placebo acupuncture, and red is real gabapentin. And the pink is placebo pills. We actually found at the end of 8 weeks of intervention, the electroacupuncture has the best effects, followed by sham acupuncture, gabapentin, and placebo pill. And there's a statistical difference between the placebo acupuncture and the placebo pill, highlighting this art of acupuncture delivery generate a much more stronger effect than just taking a pill in its sort of placebo form. And what is even more provocative is the long-term follow-up. This is after stopping acupuncture or pill for 4 months. The electroacupuncture group continued to have a marked improvement followed by sham acupuncture and placebo pill. Then the gabapentin group, their effects just went back to baseline. So over long-term acupuncture actually was better than gabapentin. So also people, the biggest critic about placebo effect is, well, acupuncture is all placebo. I would argue, so what? If the effects is drastic short term, thank you. You guys are a great audience. I typically don't get plus. And also, if the effect persists without the treatment, wouldn't a patient love that? Does a patient want to take a pill for the rest of her life? I have yet to have a patient say that. So I think really, also if we look at the side effects, gabapentin group 39.3, sham pill group, placebo pill 20%, electroacupuncture 16%, and sham acupuncture 3%. Also, there's a statistic different, like placebo pill generated more nocebo effects than sham acupuncture group. And here are some of the side effects. So one could argue if acupuncture is a therapy with more benefit and less side effect, I don't think it takes a genius for a patient to say, maybe that's something I want to try. So I want to summarize that there may be different types of needling stimulation producing different effects for different patients. As the field moves forward, we shouldn't just think about sham. We actually should do studies help acupuncturists to do acupuncture. Because I feel like I've read a lot of papers. Rarely they really tell me how to become a better acupuncturist. They typically just try to show to the conventional world acupuncture work. But I think there's a lot more to be done to understand how do we do acupuncture better for our patients, including how do we enhance that patient-doctor relationship to deliver our intervention. Second is acupuncture may target pain-related symptom clusters. Wouldn't it be nice we have one intervention, target multiple symptoms, so the cancer patient does not need to see a psychotherapist, see an acupuncturist, see a rehab doctor, see everybody in the world because they have a life to live. And the third is, compared to active drugs, acupuncture may have more sustained effects with fewer negative side effects. As much as I'm enthusiastic about my results, I have to be very realistic. Our trials is still small sample size. Until somebody wants to fund it, we have to ask for a larger trial. But if they do fund it, I'll ask you to do long-term follow-up because our gain may be in the long term. And also innovative trial design and comparative effectiveness research is really needed to move this field forward. So here's my theoretical model. As cancer diagnosis and treatment brought on, a lot of symptoms are common to our patients. We need to do research to better understand what are the etiology, mechanism, and risk factors that produce those symptoms and use acupuncture to target those symptoms specifically. As a result, we can potentially improve the adherence to cancer treatment and improve quality of life and survival for cancer patients. So I want to use the last minute or so to really welcome any of you who want to join hand to really make acupuncture part of a standard cancer care. We have to do this together from a clinical integration, innovation perspective, research, and education. And our SIO is such an organization that our next year's meeting is in Miami. The goal is advancing global impact of integrated oncology. And I hope to see many of you there. And thank you very much for your time. Thank you. Sorry. I apologize. I'm actually leaving UPenn to go to Memorial Sloan Kettering, so I don't have cards with my new information. If you have questions about research or measures, please email me. Thank you.